So these colony forming units are really high, particularly in break rooms, particularly in hallways, certainly in solid utility. And then people, because they're behind the red line, and microbes know not to go over the red line, what happens is these people traverse the ORs and they're going back and forth. And you could see these ORs that I was studying, every time they'd open the door, the ceiling tiles in the hallway, because remember you can have a drop ceiling in the hallway, would pop. And so every time they pop, because you're opening and changing the pressures on those rooms, you would get this influx of these very high CFUs in the hallways.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we speak with Dr. Linda Lee, president at Linda D. Lee Healthcare Consultants. Linda has an extensive base of experience in facilities management and environmental health and safety practice. This includes responsibility for functional management of multiple domestic and international locations. She is a nationally recognized speaker, technical expert, and author on issues related to safety, health, environmental, and regulatory affairs. She recently received her certification by the Board of Infection Control and Epidemiology. She has spent 30 years in healthcare, having previously worked for DNV GL Healthcare, CH2M Hill, WM Healthcare Solutions Incorporated, the University of Texas MD Anderson Cancer Center, and one of the original founders at Stericycle. She is a speaker and author of numerous peer-reviewed journals and publications and 3 books published by the American Hospital Association. So, Paul, this is going to be another great episode. I think we're going to learn a lot today, and we're also going to get it from a very different perspective. You heard that background in epidemiology, and she's been working in public health, and so it's going to be a different perspective, but I think it's going to be eye-opening as well.
Oh, I can't wait to talk to her with all of her background, especially in the science of air. In the operating room, we're always talking about, is it particles that can cause the infection? Is it airflow? Is laminar flow necessary or not? Or even as something as little as convection heaters used on patients. So I'm really looking forward to hearing what she has to say about all these different areas and what the science tells us.
All right. Well, we'll be right back with Dr. Linda Lee after a short break.
You're listening to the First Case podcast.
Joining us now is Linda Lee, president at Linda D. Lee Healthcare Consultants. Linda has experience as a public health practitioner and is here today to talk about environmental controls and the air. So, Linda, I just want to welcome you to the First Case podcast. Thank you so much for joining us today.
Thank you. I really appreciate being here today.
So, Linda, before we got started with the interview, we were having a little bit of a discussion just about your perspective, coming at it from maybe a little bit of a different perspective than the OR managers and scrub nurses. Your background's in public health. And so I thought maybe you could give us an overview of your experience and your background and what makes your perspective unique maybe to the ones of the hosts here on the show.
Well, thank you very much, and I appreciate the invite tonight. I look at this in a little different way. I've spent an entire career studying the air. So you can imagine I've spoken all over the world, and I always start out my talks with We're one mutant gene away from life as we know it changing. And all of a sudden, it's changed. And so in the role of a public health practitioner, which is where my background is, I really spend a lot of time trying to keep people well. And we have a great healthcare system here in this country, but we only have so many resources. And in this particular pandemic, this issue of keeping people well becomes extremely important, because if we can keep one person out of the healthcare system, that creates one more spot for someone else. And the air as a pathway, or as a pathway of disease transmission, has been there for centuries. And we've known this, whether it was plague, whatever it was, we've known that bad air, as they used to call it, is a way that people get sick. And so in the old days, we tried to keep bad air away from people so they didn't get sick. We use all of our senses to identify air we shouldn't be breathing. If something smells bad, we throw it out, or we go the other way. If we see smoke, we don't go into smoke because we know we can hurt ourselves. But this invisible threat that we're dealing with this pathogen, actually exists in healthcare all the time because we can't see it. We can't identify it. So when people say, wow, these healthcare associated infections, where did they come from? They come from things we can't see. This whole micro world, this whole very small, tiny particle that we can't see, we can't smell, we can't touch, and we can't taste, is what we're trying to protect patients prior to the pandemic, protect patients from, whether it's in an operating room or an ICU or in the cafeteria, quite frankly. And now we're dealing with a pandemic where now we have an entire population that we're trying to protect from a very small, tiny little invading creature. Well, it's not even a creature, this virus that loves to be in our lungs, and in our lungs loves to grow and loves to reproduce. So my interest in this area of the air is way before there was ever a pandemic. And I'm very concerned about keeping people safe and doing everything we can to make one less person in a healthcare situation, one less person in a hospital.
So, Linda, in your working with healthcare facilities around air quality, how much does data and data mining come into play as you're taking a look at, I don't know if you're consulting to help them or if you're trying to predict some issues like the nature of your work, but maybe talk a little bit about the impact data has in what you do?
Well, data is really evidence. And evidence is what we need. And evidence-based medicine, evidence-based decision-making is extremely important. I've got 5 peer-reviewed papers in the last 4 years where we focused on the air, whether that was in a compounding pharmacy, whether that was in an ICU, whether that was in an OR, really looking at this. Because if you look at some of the information that comes out of Europe, there are standards for CFUs in ORs in Europe. And if they test and they find this level of CFUs or they exceed it, then there's interventions that they do. We have that in compounding pharmacies. In compounding pharmacies, if you exceed 1 CFU, there's a whole intervention that the pharmacy is required to do to manage that environment. Yet, in anywhere else in the healthcare facility, for the most part, we don't have any testing for that. And if nothing else, unless there's an outbreak, we suggest that you don't test. And so we don't have the tools that we need to make corrective actions. And if you look at some of the evidence that has been collected on, for instance, SSIs or OR infections or things like that, what we find is that in many cases, it's because we choose not to collect that evidence. And so we're reacting, we're not proactive, we're reacting to infections. And so once these infections happen, then we react to them. We say, oh, what do we need to do? How do we reduce this number? Instead of being data-driven that says, how are we going to proactively, because we know these are happening and people are collecting a lot of data, but what can you do proactively? That's really been my focus, is to work with clinicians and say, what can we look at that's not traditional? What can we look at that's not hand washing? What can we look at that's not a typical pathway that these people are getting sick?
When you talk about the ways that we can prevent infections in the OR and how we react on the other side when our patients suddenly have a surgical site infection, what about the ways that we have in our ORs to keep that air flowing, to push it out so that it's going past the patient, I guess, that laminar flow? How is that helping to keep that air from causing an infection in our patient?
Well, actually, in the 60s and the 70s, when laminar flow really came into popularity, and people said, wow, it was widely accepted that during this time, during orthopedic procedures, this laminar flow, which the definition of laminar flow is almost like it's a volume of air that's moving smoothly. And the idea was to prevent airborne contaminants from the area. We know that people shed 37 million bacteria an hour in general, and that's people who are not sick. And we know that one of the biggest areas that we shed from is our ears and our head and places like that. So the idea is that if we create this laminar flow, which just by its definition is a very smooth, so all the particles are moving in the same direction. Everything is moving slowly. But we all know that when you get into an OR, that how many times are the red bags / linen bags / any bag blocking the laminar flow or the air removal system? What happens then is that air becomes almost like a ping pong ball, and it bounces everywhere around the room. So the idea of turbulent flow, which is sort of this chaotic property of the air bouncing everywhere, which is what you normally have in airflow, and the idea of the laminar flow. But in studies, there was just a study, and these are all recently, there's a study recently where their conclusion is that, and it was by James, and basically they concluded that these strict antiseptic techniques, prophylactic antibiotics, and good control of body temperature during the surgery and then post-operative care was actually providing better outcomes than the laminar flow. WHO came out, and in WHO they came out and they said that in 2016 that they really hesitated to recommend laminar airflow because it wasn't necessarily reducing infections, particularly in total joint surgeries. So laminar flow seems to, at least in the literature, seems to be very controversial at this point. And people aren't coming out and saying, no, you shouldn't have it. They're just questioning whether it's ultimately worth it because of the costs and whether or not it's actually protecting the patient, versus there have been some papers that have actually come out and said, quite frankly, that improved procedures or improved things done by the staff actually are better ways to prevent these infections. At this point, the jury's kind of out on whether or not this is a technology that may have seen the end of its useful life in just the average orthopedic operatory.
Linda, I've been in many ORs where they may have one laminar flow room, but they're doing total joints now in just about any room in the OR. So has there been any studies done to compare the outcomes in laminar flow rooms to non-laminar flow rooms to date?
Yes, there's several out. There's one in Open Orthopedic Journal, so the open access, that talks about the evidence of the use of laminar flow in total joint. And again, there's just quite a few of them out there right now that are probably less than 5 years old that say there statistically is no difference between them. And most will say, hey, it's premature to throw them out. But they're also saying that, however, that there's not a lot of evidence that say you're really improving the outcome if you do these other things for the patient. It's really interesting. There's some interesting studies related to this and being able to maintain good body temperature for the patient during the surgery and their outcome. So laminar flow is not necessarily getting kicked to the curb, but there's just a lot of people saying, is it really worth it? And is it any better? Is it any better in the outcomes? Do we see any difference than if we just had normal flow in the room? And normal flow in the room seems to have almost the same outcome if you read the peer-reviewed studies as if we were to have laminar flow. So normal airflow seems to be, and proper airflows. Now, I look at a lot of ORs, quite frankly, and I can look at a lot of things and whether they have laminar flow or not and see. For instance, Johns Hopkins did a really interesting paper on the opening and the closing of the door between the sterile core, the room, and the locations of the room in relation to the OR. So I did a study in an OR in California, and the level of contamination all around the OR is so high that when these doors open and close, and I don't quote me on this, but I thought the Johns Hopkins paper said there were like 57 door openings and closing per hour in the average case. But you can look and see, because I've studied a lot of ORs and I've studied total coliform units in the ORs. So these colony forming units are really high, particularly in break rooms, particularly in hallways, certainly in solid utility. And then people, because they're behind the red line, and microbes know not to go over the red line, what happens is these people traverse the ORs and they're going back and forth. And you could see these ORs that I was studying, every time they'd open the door, the ceiling tiles in the hallway, because remember you can have a drop ceiling in the hallway, would pop. And so every time they pop, because you're opening and changing the pressures on those rooms, you would get this influx of these very high CFUs in the hallways. Or you would go from the break room, and the break rooms were attached to locker rooms, which were attached to the toilet rooms, and then the room doors were open. So you could see this in almost every OR. So looking for these other pathways of transmission or these other pathways that these CFUs can travel to these rooms become extremely important when you're looking at reducing SSIs.
So I've got a couple follow-up questions to that. The first one being, we've got positive pressure in the room. So opening the doors, shouldn't the positive pressure be pushing those particles out, not in? Or is there something else that's going on there?
That is an excellent comment, because that is exactly what clinical people will tell me. The problem with positive pressure is you only have positive pressure if the door is closed, because as soon as you open both of those doors, you have neutral pressure. Because what does pressure do? Pressure seeks to escape. It's called pressure. So when you open those doors, the pressure neutralizes. Now, initially, the idea is that when you open the door and you feel that pressure, yes, the air is escaping. It is pushing the air out into the corridor. But when you stand there with your foot in the door talking to somebody, you're neutralizing the pressure in the room. And then if you open both doors, air is going both ways. So it becomes really important to understand that the room is pressurized, absolutely, but the door is standing open when people are talking, and that's why they studied how many door opening and closings was going on in every surgery, because they concluded that if you kept the door closed during the surgery and let the air systems operate to protect the patient, you gave another level of protection that you shouldn't be opening those doors.
When you were studying the opening and closing of the doors in the ORs, did you look at both the external door going into the hallway and the substerile door? And was there a difference in how many particles maybe came in or increased rate of infection if we only opened the substerile, or did it matter which door we were opening?
It was both, because that's where you're losing your pressure. So the substerile doors certainly will have less particles, but there are still particles. The understanding of particles and viable microbiological materials is very different, because a lot of ORs will study particles, but particles are not necessarily viable. And so you really have to study viable particles. Secondly, the issue is really of opening and closing doors. Now, in one OR that I studied, OR number 1 and OR number 2 had the highest infection rates in this hospital. OR number 1 and OR number 2 were also the doors that had the exit to outside the OR. So those ORs had the dressing area. So there's a red line, and people who are not working in the OR but putting on suits, Tyvek suits, bunny suits, whatever you want to call them, did it right there. And then when they open those doors, so all the waste goes out that corridor, everything passes those two ORs. And so every time those doors opened up, they would cause a pressure differential in the hallway and therefore in the room, and you could see the doors pop. And so the way the doors, because they're not latching, they just push open. So the way this happens then is you could see these pressure differentials actually in those rooms. So it becomes important to study the whole environment and try not to look at it myopically. Try to look at it as everything that's going on that not only could increase the level of CFUs or the colony forming units, but could also be potential pathways once those doors open up. There are hospitals that I work in where they terminally clean the room, or they clean the room and then they open the doors and the next patient gets rolled in. As soon as you open that door, whatever you've done to terminally clean that room, you're now contaminating that room with everything in the hallways. Then they roll the patient in, they shut all the doors. Those rooms then have to stabilize from a pressure standpoint. And depending on the way the rooms are designed, they might have occupancy sensors. So maybe they step up or they ramp up the amount of air that says, oh, I'm now occupied, I need more air. Building setbacks, at the end of the day, you can have backflow or backwash to the room. So there's all sorts of things that can happen in those rooms.
So Linda, what you're talking about now are really room design issues or operating room suite design issues. What changes are being made in design to help reduce the potential for the particles getting into the rooms? What's the latest on that?
Well, that's a great question, because there's what's called the basis of design, and then there's the operation of the facility. So the basis of design is good. The basis of design, the way the air is required under ASHRAE, and ASHRAE is the body that sets all the standards, so to speak, for air. When you look at the basis of design, it's good. It's positive pressure. It's all the things you want to have. It's the right mix of outside air to inside air. So it's not about the basis of design. It's about the basis of operation. And so infection control practitioners put a lot of controls into the way the rooms are set up. But then what happens is then you introduce people into it, and people get really busy, and it's crazy. And, that's one surgery after the next, and turn the room and get people in and get people out and call people, and things happen. The basis of design, I don't think, is necessarily an issue. And I've worked on designing ORs in many countries. I worked in the Middle East. I worked in China. I've worked in Brazil. I've worked in Mexico. I've worked all over the world. It's not really about the basis of design. It's about how things get done. Now, are there tools that might help people communicate better? There was a really good study that I read about people who did orthopedic surgeries who wore suits, moon suits, whatever kind of suit you want to call it, but they had PAPRs or they had positive airflow respirators on them and so forth. And some of the people who were wearing them wondered if the levels of contamination were because of the air coming out of that and interrupting the laminar flow. So there's all kinds of things out there to try to understand why these infections happen. But what I'm finding in many of the studies that are out there is that it ultimately comes down to how people interface with the environment, how people interface with the room. And I've done a lot of inspections or a lot of surveys in ORs, and a new piece of equipment comes in, and then there's an entire cabinet that gets put in to store all of the data that has to be used to run this equipment. And so you've got this cabinet. No one ever cleans in that cabinet. And you open this cabinet, which is, by the way, drawing air in from the room, and it's filthy in there. There's dust and there's dirt and there's debris and there's all sorts of things. So think about it in this term. Don't think about it in terms that nobody cleaned that room. Think about it in terms of the fact that that dirt and dust and junk was in the room to start with. It just collected in that spot because it was drawing more in to cool the computers than was going out of the room. So if we think about the amount of debris that's just in that air, and that's an OR. So when we find this sort of visible stalactites and stalagmites of dirt and dust, and we go, oh, we got to clean that, what we have to be saying is, why is it there to start with? Because the way the room is designed is that in many cases, particularly if we're talking about laminar flow, there are HEPA filters. There's pre-filters, goes through a HEPA filter, gets delivered to the room. So when you think about that, and I've seen this in all kinds of rooms, just open a cabinet that's got a computer terminal in it or a CPU. And so that dirt and dust just happens to be accumulating there, but it's there to start with. So the way I think about it in terms of cleaning the room is that terminally cleaning the room isn't just where the table is. And I know that you all know that, but if you were actually terminally cleaning the rooms, like I look at the light sockets in many of these ORs, particularly that are, at the 3 foot or 2 foot level in the room. And if I can see dirt and debris in there, remember the room is positive. So any little nook and cranny, the room air is being blown into it. The wall cavities are probably negative. And so when you look at these things, look at the path of travel, and then look at how much debris is building up in there, because that debris is not necessarily, could be inert. It's not necessarily pathogenic. But what it's telling you is that there's a whole life cycle to this room that we're not addressing, either in the cleaning process or in the maintenance process or the handling process. We have HEPA filters and people change them out all the time. Do they ever retest whether those HEPA filters are actually sealed? That could be part of the issue. You're not retesting when you're changing your HEPA filters. You're not recertifying the HEPA filters, you're just changing the filter. And so there's a lot of things that happen that don't necessarily go to the design, they go to the operation.
Wow, I can see a lot of people listening to this going in and taking apart all their computers in the OR and blowing out all the dust. But okay, so I have another area of concern or a question that I've seen a lot of controversy about, and that has to do with convection heating devices. Warm air blowing to keep the patient warm, which you say temperature control is very important, but how does that air impact the flow of contaminants within the OR?
Well, again, it depends where it's located. It depends how clean the OR is to start with. It depends on a lot of things because any air movement in the OR. So think about it in terms of turbulence. So when you think about air movement creates turbulence. The idea of air movement in general is to move the air down. And this is the difference between turbulent air or turbulent airflow and laminar flow. The idea on laminar flow is to have this very smooth air pathway where the air comes down and it very smoothly. So the particles move with each other in one direction. What happens with turbulent airflow is the air normally comes down. It creates what are called eddy currents. So the room air comes down and sweeps down, and then normally, now not in an OR, but normally the ventilation is removing it from the ceiling. Or maybe it's removing it through a grill in the door and there's no exhaust. And so what you want to do is you want to keep as much away from the patient as possible, i.e. that's why they created laminar flow. The problem with laminar flow, or at least if you read some of the peer-reviewed papers, is that this air is being disturbed either by all of the extra stuff in the room. So let's say you add a blower. You need a blower because whatever equipment you're using is now blowing out. That changes the air patterns in the room. And so as these air patterns change and they get interrupted or they get disrupted, it creates a different scenario. So then some of these pathogens that you're either coming in through the doors are coming in after you've terminally cleaned the room, you have the door open, people coming and going from the room, delivering things, supplies, etc. to the room, are creating this whole pathogen loading. Once you've created this pathogen loading, now this disruptive air is now also got opportunities to contaminate the site or contaminate the wound. What these peer-reviewed papers are saying is that these other steps, these techniques, these aseptic techniques, this prophylaxis, these way we're treating the patient are actually doing more to protect the patient than just saying, okay, we're in a laminar flow room, so everything's good. I think that may be, and I'm not saying anything about anyone doing anything clinically. I'm just saying this is what the evidence is saying. And so I think as we rethink about the air and cleaning the room, I go into a lot of ORs that people tell me have been terminally clean, yet the tracks with the lights on it. Well, no one gets up there to clean it because it's 12 foot in the ceiling, yet the air blows down right over it. And no one's ever been up there to clean the tracks, whether it's the light, whether it's a gantry, whatever it is. And there's not a procedure for doing that because it would require somebody to bring a ladder in just to get to it. And so thinking about the room holistically becomes really important. But anything that interrupts the airflow in the room, so by moving another piece of equipment in there, you're now changing the dynamics. And that's why I said there's the basis of design and then there's the operation of design.
So what about when we're doing a case and there's discussion back and forth about whether or not covering your instruments is good or bad, but does covering our instruments help protect from some of that disrupted air? Would that help prevent an infection because the air could not get to our instruments if they were covered?
There's so few actual studies because we don't traditionally study the air. We don't traditionally just do normal air monitoring, even particle sampling. We don't invest in technology to do that. So does the amount of particles go up over a case? And if you look at it from, let's just say if you had a construction site, you probably have somebody that walks around every day with a particle counter, and they can tell that from that construction site, particles are getting out. Particles don't necessarily mean that they're viable and going to make you sick, but it tells you something's going on. So if you put, say, a particle sensor into a room, an OR, and you used ultrafine, you're still looking at greater than 3 micron, but you're looking at particles and you're saying, are the particles going up in a room during anything that's going on? And if you use that as a sentinel identifier or as a surrogate, and you said, okay, when we do this procedure, the number of particles go up exponentially. Whatever that is, you would establish that. What is going on that we want to then reduce those? And so I think there's a whole body of evidence that needs to be collected that would help to look at the significance of this. And then you could also then do viable particles. Does this really mean anything? But I think there's a whole body of evidence that still is out there to be collected. There's just not a lot of people looking at it, because most of the time I get into a lot of very academic discussions, particularly with clinicians, in relation to contact pathogens and airborne pathogens. I spoke at an infection control, whatever, not too long ago, and I got into this whole big discussion about whether this current coronavirus was airborne. And of course, there's a lot of opinions about it, and even CDC's gone back and forth many times. But at the end of the day, as an industrial hygienist, one of my focuses is that I believe what's on surfaces is in the air, and what's in the air is ultimately on surface. And it's all about molecular weight, and it's all about the size of the particle, and it's all about how it fractionates. So if you can think about a droplet as it fractionates, if you look at temperature and humidity, those are huge drivers in viruses. They also are in molds and funguses and all that too, but they're really drivers. And so if you kept the humidity high enough where these larger particles can't fractionate, and yet you kept it low enough where you weren't growing mold on the walls of your ORs. But if you think about the way these particles fractionate, particularly viruses, is they love to start to dry out. Then they become smaller and smaller and smaller and more airborne. And so when you look at these things and you look at this, the whole picture, and you say, okay, what are all the things that we're doing? That's where it really becomes important. So when you're talking about whether you should cover your instruments or not, it's really understanding the environment. It's not as easy as just saying yes or no. It's how clean is the environment to start with.
Well, Linda, that was extremely informative, but also incredibly fascinating. This whole idea of fractionating and viruses getting more airborne or aerosolized. I really like the way that you put all that together, and I can't thank you enough for coming on the show today.
Well, I appreciate you guys inviting me. That was really nice of you. Thank you.
That was Linda Lee, president at Linda D. Lee Healthcare Consultants, and she's a public health practitioner, and you can really tell in listening to her during this interview. Melanie, one of the things that I really like is the way that she's able to talk about what we live every day, but translate it. And she's also got a very unique perspective on everything, especially when you talk about trends in OR design and how to reduce these hospital-acquired infections. And even that term fractionate, I think I intuitively knew what it meant, but I'd never really heard it described to talk about how viruses get more lift and can travel as they fractionate in the air. So it was very interesting. I definitely learned a lot today.
Oh, I did too. It was fascinating to listen to her talk. And what struck me was when she talked about the design, she kept going back to how it's not necessarily the design, it's the operation. And that really means it's the people. And thinking about how we as staff in the OR are either preventing or encouraging infections just by our everyday work activities. It's not necessarily the big stuff that everybody focuses on, but putting your foot in the door or opening a door when you shouldn't or paying attention to all of that airflow is so important to keeping our patients safe every day.
All right, that's going to do it for this week's show. As a reminder, you can help support First Case by subscribing on iTunes, Stitcher, Google Play, and Spotify. We would love a rating and a review because your feedback is important to the show. And on behalf of Paul, Melanie, and myself, thank you for listening to this episode of First Case.